I'm Bob Vonderheide. I'm the director of the Abramson Cancer Center, and it's a real privilege to welcome everybody to this session. We at the Abramson Cancer Center are delighted to partner with the Vassar Center for BRCA for all the events today. Let me thank the Vassar Center founders, Mindy and John Gray. Hooray. And along with Sherry and Len Potter, incredible vision, now 12 years at this, and I think we saw today the incredible progress. And very recently, Mindy and John inspired us with another incredible round of support to start a second endeavor, the Vassar Center for Interception, which is trying to go after the earliest stages of these cancers before they've had a chance to take hold and to eliminate them and change lives. So now it's my pleasure to introduce the moderator for B&D today, who is Jill Werman Harris. Jill is a journalist with a background in bioethics who has written for medical journals, the New York Times, Tablet, and the Jewish Forward. Jill has formerly held a faculty appointment at the Albert Einstein College of Medicine, where she wrote curriculum and facilitated professional development on humanism and self-reflection for third-year medical students. This room is actually the main room that the first-year medical students use. You notice none of them are here. You feel, yes, we feel them. And Jill has actually moderated several panels for the Vassar Center, and I know will lead a very informative and thought-provoking discussion today. So, Jill.
This is the part of the symposium where we get to share Vassar's scientific impact and learn more about our panelists' expertise and what drives them forward in their dedication to the progress we so desperately want to see. Now, as someone who reads and writes about medicine and has admittedly watched far too many episodes of Grey's Anatomy, I join you in really trying to understand the loss of BRCA function and the complex set of diseases associated with it. So whether you're here as a carrier making multiple difficult decisions, or a caretaker who's providing critical support, or a patient navigating the immense challenges of treatment, let's take a look at some of the things our panelists are doing and thinking about these days. It's my pleasure to introduce Dr. Susan Domchek, the Executive Director of the Vassar Center for BRCA, who so thoughtfully put together today's panel. Thank you, Susan. Moving down the line, Dr. Ken Offit, Dr. Gilbert Welch, and Dr. Clare Turnbull. I had the chance to speak to each of you in advance of today, and our conversations were really thought-provoking and inspiring, so thank you all so much for being here. I want to start today by delving into the roots of BRCA and talk for a minute about DNA, the fundamental molecule that carries genetic instructions within our cells. Now, DNA is extraordinary and robust, but it faces all kinds of damage from the environment or simply by doing its daily chores. So Susan, I'm going to start with you. We humans have evolved to handle such damage. Can you tell us more about how our bodies rely on genes like BRCA to kind of guard our genetic integrity, and what mutation carriers face within that context?
It's a great question. So as you mentioned, there are daily insults, everything from pollution to radiation to alcohol and other things that create damage to our DNA. And there's multiple different DNA damage repair mechanisms, and they repair different types of damage. BRCA1 and BRCA2 repair a certain type of damage, which is in double-stranded breaks. So remember, there's two strands of DNA, and it's when both of those strands are broken. That's where BRCA1 and BRCA2 play a really important role. So if you're born with one bad copy of BRCA1 or 2, we call that a mutation, or these days a pathogenic variant. We like to try to continually mix up the terminology just to make sure you stay up to date. But now we say BRCA1 pathogenic variant. And if you're born with one bad copy, that significantly increases your risk for the development of cancer. And the cancers that are most clearly linked are breast cancer, ovarian cancer, and specifically for BRCA2 more than BRCA1, pancreatic cancer and prostate cancer.
So there's this puzzle, right? You referred to the good working copy failing, and we don't really know why that happens. But is there some way to sort of metaphorically, like, send it to a Zumba class or like CrossFit where it can become more resilient?
Well, so it's a great question. So you're born with one good copy and one bad copy. So in general, that means, very simplistically, that in your cell, 50% of the protein is made. But 50% doesn't seem to be enough. And for reasons that we actually don't quite understand, having 50% of, say, BRCA1 increases the chance that you lose that second copy. So most, not all, but most cancers that develop in the setting of having an inherited bad copy of BRCA1 or 2 have lost both copies. So the question becomes, what is the amount of protein that we need to keep the cell functional? You'd think we'd actually know that answer, but we don't really. We don't know if it's 75% would be enough, or do you really have to get to 100%? And we think about other genetic conditions that have been really kind of innovative in how they've solved problems. You think about cystic fibrosis, where they just have to go from zero, nothing's made, to a little bit being made, and they completely change what happens to these individuals. So in BRCA1 and BRCA2, we've got to figure out some fundamental issues of like, what's the level we need? And as you said, can we juice up the good copy, or can we just find ways to prevent it from going from one bad copy to two bad copies?
Is that what some people have been reading about when they hear about these exhausted cells?
That's a little different. So when we were in the last 2 days, if you've sort of been around, we were talking a lot about exhausted T cells, which are a type of immune cell that comes in. And there's always been this sort of, if you will, paradox that in BRCA1 and 2, those initial, when you lose that second copy, it looks like the immune system's really active. But when you look in tumors, those tumors don't respond that well to immune therapy. And it's likely because those immune cells are actually tired.
Yeah.
They kind of came in, they tried to do their job, they couldn't quite get it done, and now the cancer has developed and it's escaped the immune system. So those are all potential strategies for interception, which is, again, interception is trying to go from that one bad copy to when you've got cancer, that first cancer cell, and everything that happens in between, and trying to target it. And that may be this idea of, so the amount of protein, that might be how the immune system interacts with those early changes. Those are all things that we're really interested in.
Your work showed for the first time that a PARP inhibitor reduced the risk of breast cancer recurrence and improved overall survival. And innovative ideas like that, or investigations into immune T cells, these kind of ideas demand sort of a radical way of thinking. And I know that you personally yearn to give patients a better choices than what we've got. And I know we've talked about the Cancer Interception Institute that holds tremendous hope for future breakthroughs and discoveries. But can you tell us more about it and about the immune system and what you want to accomplish ultimately with it?
Exactly. We don't love telling 25-year-old women that their options are somewhat limited. And although we do have good screening for breast cancer, we don't have good screening for ovarian cancer. We're talking about early oophorectomy, the removal of the ovaries. We're talking about a removal of the breast. These are sort of life-altering decisions that women make. So we want to be able to do better. In order to do that, we have to come up with the right strategies that are acceptable to patients, that don't have much toxicity, and result in a significant decrease in the risk of developing cancer. And we do have true ideas now. I mean, if you told us like 15 years ago, all those ideas were sort of nascent. But now, there are ongoing trials looking at these issues. There's a very large phase 3 trial. Phase 3 trials are comparing a drug to a placebo. And these are in BRCA1 mutation carriers looking at a drug called denosumab, which is a bone strengthener medication, which has very good preclinical evidence for why it may reduce breast cancer. We do have a vaccine trial, which is in very early phases, but we are vaccinating healthy BRCA carriers. These are people without cancer who volunteered to get a vaccine that honestly we don't know the long-term effects on. So this is, you can see how much of a collaborative approach this is. I mean, it has solid preclinical and early clinical evidence, but still, this really takes a village. And so we hope that there will be other drugs that we can put into this idea, whether it be a PARP inhibitor or whether it be another drug. We need all the basic scientists and translational scientists in this room to help us move the needle forward.
Timeline? Any sense?
Oh. Longer than anyone in this room wants, and as fast as we can. That's my
Science
best
moves
answer.
slowly sometimes. You have something called a pre-cancer atlas, where you've collected a lot of healthy tissue from mutation carriers. And I think, Ken, you had actually made reference to that in your talk earlier. Can you tell us what that is?
So it's getting back to a lot of these same issues, which is we have to understand the biology of these earliest lesions, and in order to do that, we actually have to look for them. And in the past, mostly we've looked at cancer, and then we've looked at things near the cancers. But what we really need to do is collect as much tissue as we possibly can. So fortunately, several investigators in this room are working on this, and my colleague Kate Nathanson, and in collaboration with the Gray Foundation, we're collecting as many samples as we can in the breast, in prostates, and pretty much any tissue people will provide to us, because in order to do this, we need to look very, very closely. And as been kind of articulated at this meeting, we can have hypothesis-driven approaches, but in some ways, we just need to cast the net wide, look at pretty much everything we can to see if we can start to discern patterns and come up with those earliest interventions.
Not enough appreciation sometimes is given to the patients who do donate tissue, and you have a biobank. You know, I don't know, a lot of people know what that is. Do you want to just share briefly?
Sure. I mean, we are incredibly fortunate, and Ken will probably likely speak of his, and then there's these huge biobanks in the UK and at Penn, but we offer our patients an opportunity to participate in research, and we're lucky enough that most say yes, and that can range just from DNA from a saliva kit to providing blood once a year so that we can look for early detection assays, to at the time of surgery, individuals being willing to provide some of their tissue. But we have, over 2,600 individuals who have BRCA1 and 2 mutations that we have DNA on. We have more than 1,200 that we have yearly plasma samples on, and we are just increasing our collection of healthy tissues. But it's all of this, and despite that, the reason for collaboration is that one center still, we can get a start to it, but we need many centers to collaborate and also provide those quantities to really start to see things.
I was just thinking that maybe if we could get tissue from the TikTok users, you'd have a big biobank.
Sample processing remains a challenge through TikTok, but we'll work on it. No.
Anyway, thank you so much. Moving on to Dr. Ken Offit. Your research lab identified the most common mutation associated with an increased risk of breast and ovarian cancer among those of Ashkenazi Jewish ancestry. And in 2002, you offered a critical New England Journal of Medicine paper that really set the standard for oophorectomy as the really great life-saving intervention for carriers. The hope, of course, is that one day preventive surgery will be rendered a historical curiosity. But for perspective, can you briefly compare the benefits of oophorectomy and mastectomy in terms of cancer risk and overall survival?
Maybe it's good to, sort of set the historical, perspective. It's funny, I thought, somebody, the older person in the room, but earlier today, Gil said that he was born in 1955, and I was thinking, good, there's someone else. It's like, that was our year. So we are, and if you know how old that makes me, right? And so this was before BRCA. I actually started doing this, and I remember a conversation with Francis Collins, who, as you know, kept being called back into public service, even beyond our age. And he said at the time, as we found that founder mutation, which was the common mutation in BRCA2, he said, Ken, maybe this won't work out. Maybe there won't be anything that we can do, because they had this experience in genetics with Huntington disease, where you had a genetic condition, but there was really nothing that was to be offered. And I know it sounds incredible to think now that I would have had that conversation with him, but I even still have the slide. He gave a quote of, I think it was Sophocles, about how it wasn't good to be wise when wisdom profits not. He was very literate, if you know. And then, of course, it's not right. So what we can say now to folks is your survival with this mutation will not be impacted compared to someone in the general population. Okay, that's extraordinary, right? Now, you may not like how we have gotten there, in terms of what the options are, but sometimes when I'll just say that in a counseling session, even to just sort of get in the mood, that's hugely reassuring because, fatal mutation, lethal, all of that kind of thing. And how did we actually do that? So yes, the surgeries we can talk about, but I'm married to a radiologist, and I may have a daughter who's going to do radiology, I just found out. So I should be careful to say that breast MRI has been a powerful adjunctive tool here that we did not have when we started this. We just had mammograms when we started this. And the breast MRI came to its maturity right when we needed it. And Stephen Nayrod's in the room and did some of these studies. Breast MRI, the sensitivity, if a mammogram in a young woman is only 40 to 50% sensitive, a breast MRI is up in the 80 to 90% range. And that's tremendous, but it's more expensive, more time consuming. We did do preventive mastectomies before BRCA. People seem to forget that, And I always like to point out that, paradoxically, when we have the genetic test, we're able to tell daughters, 50% of them, you don't need to do surgery, okay? Right. And the huge reassurance of the negative test sometimes gets forgotten,
that's a good
drowned out by the fact of the positive test.
Yeah.
So sure, we have the preventive surgeries, and then our surgeons have gotten incredibly good at doing these surgeries with now, nipple sparing surgeries and skin sparing, and we didn't have that, when we started as well. Now, what you pointed to about the ovarian surgery, the ovarian surgeries we did after childbearing was complete, because that was about the time at which we saw those mutations. And by the way, we say this in we're in a medical school room. The reason that you can have these Ashkenazi mutations be as frequent and common as they are is because they couldn't have penalized generations of women to reproduce, right? Because then there would have been a selective pressure against this. Do you follow this, class, right? So you know that these events were happening after childbearing.
Yeah, they're living long enough to have children.
And that concept is very important to say to young women who are terrified of getting ovarian cancer, whether they're Jewish or not, because you can say, look, you're not going to get ovarian cancer in your 20s. It's not going to happen because it couldn't have happened for this mutation to have come to the frequency that it did.
That kind of positive news is so important. To your point about oophorectomy not impacting overall survival, and as well having...
Well, I do want to make it clear that oophorectomy does impact overall survival.
Positively,
and
I'm saying.
Dr. Domchek actually wrote that paper. So the one that we wrote, it's important to say. So we wrote the NEJM paper that showed that it worked, and it showed that we found, and this was amazing, 4% of the cases we found microscopic ovarian cancers, which I'd never seen at the... I don't know if we're the best, but we're certainly one of the biggest cancer centers, okay? And I never saw that at Sloan Kettering until we started doing preventative surgeries. And these are curable ovarian cancers, right? So that alone would have done it. But then a few years later, Susan actually wrote the paper that proved sort of the icing on the cake that yes, mortality was decreased. We were literally saving lives, which we inferred in our paper that we would do, but then it took a little bit longer to prove that. And those deaths we think now would be averted by doing these surgical procedures. So I'd say, and Susan I know agrees, this is our single most powerful tool to save lives in these families.
Yeah, thank you. Something that never fails to capture my attention is the cohort of older carriers who never developed cancer despite having a predisposing mutation. And right now you're currently working on a really exciting area of research called genetic modifiers. Can you briefly define what SNPs are for the audience and polygenic risk scores, and then tell us about this amazing area?
There are individuals with BRCA mutations that live to very late age and never develop cancer. And I observed this early on. We'd have a 70-year-old woman with a BRCA2, the Ashkenazi founder mutation. Her daughter would be 30 and she would have breast cancer. So what's going on there? So what we did was we essentially collected all of those folks around the world through an international collaboration, and then we did a genomic comparison of all of those older women that never got a cancer with the susceptibility in place, and the women who did get cancer with the same susceptibility, and genomically compared the two. That's how we found the modifiers, right? And we used the technology of the day, which were these gene chips. And what we were measuring were SNPs, single nucleotide polymorphisms, that are genetic variation that make you a little bit different than the person next to you. And these SNPs are common. There are 20%, say, of the population will have a variation of a SNP. Not rare, but very common. And a panel of these very common changes defined risk for breast cancer. And in BRCA, they actually serve to protect you, to be that older woman who never would get cancer, or to cause you to have this earlier risk. And it's true for the BRCA breast cancer, and it's true for the men who get prostate cancer. The same markers, these SNPs, can be protective and they can increase risk. And this is something that, that I've kind of focused on recently, and the project I described today, and I think partially is the one that we're going to lean into with the help here of this foundation, is to identify what those pathways are. And the hope is that we can target them. And that's our way of saying make a drug.
Yeah.
Right?
And in the meantime, give carriers a more personalized risk of developing cancer so they can be aided in making the decision to have surveillance and maybe wait for a cancer if and treat it if and when it happens, or have a prophylactic mastectomy.
Yes. And the person in the room who did that is sitting right there in the Kelly Green, and she's a PhD psychologist who is running the study that Susan and I and our good colleague Judy Garber in Boston are contributing patients to. And I think we're the only place in the world where a woman can come with a BRCA mutation and have this modifier risk to see if she's at the high or at the lower end.
Very interesting.
I don't think anyone's doing that. It's in a research study. Mark Robson, if he's here, has been the linchpin of making this happen. And she reported today on some of the outcomes, the uptake, and my take, I'm always the cup is half full, guy, is that there's a lot of relief also that comes in this.
Yeah, and speaking of which, when you see patients, you, like Dr. Domchek, are a physician scientist, and you were extremely transparent when we spoke about the challenges of research. It can be an arduous path which doesn't always yield results. Can you talk about the difference between your clinical work and the work of research?
Well, I know that resonated when we discussed it, I know
have better memories than you.
Yeah. But I guess I was in a mood that afternoon. And I was, the difference is that, and I said some of this in the talk today, the experiments that don't work. My father-in-law was a great cardiologist, Ed Sonnenblick, who was at the Brigham and at Harvard Medical School, and he said, so many great theories died for want of those nasty facts. I remember, and so you have these great ideas. A lot of science is predicated on taking risks. This modifier experiment is a risky experiment. We're going to make it work, right? I'm convinced in it. But each step of the way is a minefield. And in science, very often, we were talking at this conference today. We make the organoids, and the organoids are not passing, and they're not viable. So we try again. The experiments can fail, but and I know this is true. We're physicians, right? On your worst day, if you are a clinician, and I do this, my wife sometimes says, "Why are you still, doing this?" I said, "Well, your worst day, you'll have a connection, interpersonal connection with a family, with a patient, and they might have advanced cancer, and you're telling them about a PARP drug, or they might be reconnecting with a family member who they don't feel they can talk to, and you help to mediate." And at the end of the day, the physician part of the physician scientist is always animating and always sustaining.
And being a healer.
It's very important because the science is very, very difficult.
Right, and I wanted to share, I love this quote about when research hits a wall, and I thought I'd share it. It says, "We've not answered all of our questions, nor have we solved all of our problems, but we are confident that we are confused on a higher level about more important things."
Now, this is all nice, but this is a public audience, and I just want to be sure that we're clear, Yes, there are these failures, but the trajectory, the bend here, okay, is towards progress.
Yeah.
And that's very important. And we have made real progress
Right.
from when I had that conversation with Francis
Yeah,
Collins.
interesting. Thank you so much. Very, very interesting. Moving on, something that I think about a lot is how much our overall healthcare system, the model in which we all live, is dominated by risk controlling and risk reducing. And we see it in our medical testing, we see it in our screening, we see it in our consumer products. But is that a bad thing? And if so, why? Well, Gilbert Welch has been thinking about that for a long time, and his work focuses in the general population, not among carriers, on cancer screening, overdiagnosis, and overtreatment. So this is an interesting, different kind of topic, and could you start, Dr. Welch, by telling us more about what your research has made increasingly clear?
Well, I will.
Thank you.
And thanks for having me. And I want to be clear, I'm talking about general population screening. I know actually very little about genetics, as Ken will attest. But of course, it's not all about the genes. And there's been a strong belief that the best way to deal with cancer is always to catch it early. And it's led us to, increasingly look for early forms of cancer more aggressively. And I think some of the things I've been struck by is first how weak an intervention screening is. It usually has a relatively small effect, if it has effect in a well-demonstrated trial. And you literally, at the general population level, need to screen thousands of people screen about 1,000 people to help one or two. And so, and that may be a good thing for those one or two, but I've been interested in what happens to the other 999 or 998. And screening comes with some real costs, and I'm talking about human costs now. I'm not take money off the table. There's, of course, the problem of false alarms. This is a problem that can be very scary for individuals, but more concerningly is often they're not quite ever put to rest. The people aren't told, oh, the test was wrong. There's something wrong with you. You're at some elevated risk. You have dysplasia, or so forth. And I've been also very interested in the problem of overdiagnosis, which refers to the detection of things, abnormalities that meet the pathologic definition of cancer, yet are not destined to cause the patient any signs or symptoms. So I've been concerned that we were actually overinvested in cancer screening to the detriment of population health.
So I'd love for the audience to learn about your animal analogy.
Well, I want to make clear it is not my analogy.
Okay.
It gets
Sure.
attached to.
Sure.
We're trying to figure out whose it was, but it's probably Kryle's. George Kryle, a cancer surgeon at the Cleveland Clinic. But anyway, let me tell you, it's the barnyard pen of cancers. Yeah. And it is an analogy to try to give you some sense of the heterogeneity of cancer progression. And there are three animals in the barnyard: the birds, the rabbits, and the turtles. And the goal of early detection is to fence them in, that is, to catch them early. And you immediately see the problem. You cannot fence in a bird. The bird's already flown away. And these represent the fastest growing cancers, the most aggressive cancers, the cancers that are already spread by the time they're detectable. So screening doesn't help the birds. The question is, can we treat them? And increasingly, we can. The rabbits are hopping around, and you can catch them if you build enough fences. And these are the more slowly progressive cancers that screening may help if earlier treatment is reliably better than late treatment. And then finally, there are the turtles. And the turtles, you don't need any fences because they're not going anywhere anyway. And these are, as I said, abnormalities that meet the pathologic definition of cancer, but are not destined to cause signs or symptoms for the patient.
Mhm. And you've seen that in your own practice, I know.
Absolutely.
Yeah.
And probably when I think I'm a primary care physician, and we all of my age lived through the advent of PSA.
Mm.
And the advent of PSA was a remarkable time where we went from like no one having prostate cancer to the entire clinic. Now, I'm overstating it a little bit, but it was palpable.
Mm.
And all of a sudden, general doctors began to recognize the problem of overdiagnosis.
And I think the scientist who first identified PSA nearly half a century ago called it a profit-driven healthcare disaster, ultimately. So, to your point.
Yes, it was.
You have brilliantly articulated that the best screening test isn't the one that finds the most cancer, but the one that finds the cancers that matter.
Absolutely.
What are your thoughts about multi-cancer detection tests on the consumer market like Gallery or CancerSeek that aim to detect various types of cancer before symptoms appear?
Well, first, I want to say I think the technology is frankly amazing.
Yeah.
I mean,
sure.
the fact that you can sort of separate normal DNA from tumor DNA, I don't know how you guys do it, but I mean, it is remarkable, and it may prove to be very useful in cancer patients. It may be very useful in diagnosing people who you suspect have cancer, but you can't find. But the real interest, of course, financially, is to move to a population-wide strategy of screening.
Mm.
And that's, of course, where the money is. But that's when I get worried. You may be surprised, given that most of my work has been in cancer overdiagnosis. I don't think the tests themselves will cause a lot of overdiagnosis.
Right.
I don't expect an indolent cancer to shed DNA into the blood.
Mm.
And in fact, some of their own scientists have been touting this. They won't cause a lot of overdiagnosis.
Mm.
Instead, what they will largely do is find late-stage aggressive cancers. That seems to be, at least in their early work, what is being detected. And so they'll be finding aggressive late-stage cancers, and whether that helps people to find them a little earlier, because many of them are about to present clinically, is an open question. That's why we need a randomized trial. And it could be a harm, right? Because all of a sudden you're telling someone at a time they were otherwise asymptomatic that they now have a deadly cancer. And you've started treatment, and treatment does cause symptoms. And so the toxicity of treatment may only be advanced. So this is the kind of thing that we really need to know leads people to live longer. I mean, that's the kind of thing we've really got to find that out. One other problem, if I can, and that's the false alarm problem. That these tests aren't perfect. None of our tests are perfect. And some will detect a cancer signal that is not right. There is no cancer. But we'll spend a lot of effort trying to see if it is, and doing a lot of further imaging and testing. We'll do some overdiagnosis during that period when we start imaging and so forth. We'll start finding some nodules and so forth. But I worry that at some point people are going to be wondering, well, I have a cancer signal, but you can't find it. And maybe it's beyond the ability of our current technology. So the false alarms are relevant there too. And I guess finally the thing is, this is going to cost a lot of money, and money does matter. And I'm afraid this is really going to siphon resources away from the people that most need our help, people who are sick and suffering.
Right.
And I think we're beginning to pay way too much attention to the well as opposed to people who are acutely sick.
It's an interesting point, and it leads to something, it raises something that's really essential and often not talked about, which is that these screening tests, or people who want to go out and take these consumer tests, we all hold very unique values and personal perspectives on how we want to manage our own health. Some people want every screening test available, others not so much. Should we be exploring and defining our thoughts on our relationship with the healthcare system? Like, should we all kind of think about it in advance? And I'm wondering if that kind of self-awareness can actually contribute to health outcomes.
Well, I would say absolutely.
Yeah.
I think we all need to think, particularly as we age, what kind of relationship we want to have with medical care. I'm very hesitant to say this here, but I will. It's not all about cancer, right? I mean, healthcare isn't all about cancer, and that's not the only thing. There are a lot of things we could worry about. There's a great interest in testing right now. Everybody wants, we can get tested for so many things, and there's only going to be more. And I think we all have to begin to ask the question, particularly as we age, to what extent do we want to be playing that game? It's the quickest way to become a patient and to become medicalized. And I want to be clear, I'm a conventionally trained physician. I think medicine can do a lot of good. But I think it's particularly in people who are actively sick and suffering. The deal's much finer for people who are feeling well. Right. And so I think we all have to think to what extent we want to engage in the system when we are feeling well. That is excellent point. That's a question for me.
Thank you. So interesting to think differently. Moving on to our next panelist, Dr. Clare Turnbull. Clare, you are a clinical geneticist with a background in epidemiology, and you use data to answer questions around cancer susceptibility, like how to manage people at risk and how to implement policy around getting tested. And we're going to get to the issue of population testing in a minute. But first, for those that might not be familiar, can you explain your work in the area of variant interpretation and why it's so important?
Yes, so thank you. So those of you who heard Ken's talk, he mentioned buses, variants of uncertain significance. And in the early days of genetic testing, we were cost constrained. So we only tested these large multi-case families, and we had more rudimentary technology, which only found the most damaging mutations. So that was relatively simple. There was a high prior, and we only found bad mutations. But as we've tested more and more people with less severe disease and sometimes completely unaffected people, and we have this very sensitive sequencing technology, and we can sequence the whole gene, we become increasingly aware of finding changes in genes that we don't really understand. And we have this simple sort of paradigm that gene changes are either very high risk for breast and ovarian cancer, or they're completely normal. And of course, Mother Nature's sort of laughing at us because each gene change is individually very rare and has its own individual risk of breast and ovarian cancer, but we can't quite get there. So I think this is a problem that maybe those outside genetics think is a solved problem, that we can just sort of classify our variants happily. There are some exciting technologies on the horizon. So MAVES, so it's an acronym, Multiplex Assays of Variant Effect, which bring together CRISPR, so knocking in thousands and thousands of different mutations in a single experiment, and then using deep sequencing to quantify the level of cell survival. So you can do sort of 10,000 experiments in a single go, and historically functional assays, you could look at a handful of variants. So we are beginning to get there, but we still need to be able to understand the MAVE status. So there's a bit of circularity to this.
Are we kind of in our infancy of understanding this in a way from what I'm...
I think we have quite simplistic ways of classifying the variants and ascribing risk to the variants. So there is a long way to go to get that more precise understanding. But yeah, these technologies, absolutely fantastic.
You're involved in gene discovery as well to find new susceptibility genes. What are some of the challenges, and tell us about it?
So sort of when I first started my PhD, it was, well, I guess Ken sort of, those early glory days of gene discovery and linkage and locking the lab door. And then a bit later as new technologies emerged and we had Sanger sequencing, then next generation sequencing, exomes and genomes, genome-wide association studies. But actually probably, and I think again Ken sort of alluded to this, I think we do need to recognise that we're asymptoting, we're flattening on that curve. And you will find new genes, but they're very, very rare in breast cancer cases. They have very modest effects. They're almost so rare that we can't quantify those effects very well. So you really question, I think, there's a point at which we stop. And I think that point is as again, Ken was illustrating, is thinking actually, let's look at the genes we have. Let's understand how they work. Let's understand how to manage those patients.
Right.
And actually, let's do a bit better go finding the carriers. Because likewise in the UK, we did a pretty good survey. We're at about 5% as well. So there are better ways of finding people for these high-risk genes that we do know pretty well how to manage them, albeit that we could be doing better.
So focus on the big hitters, as you're
Yeah, I
saying.
mean, the big hitters where we have interventions, that high risk of ovarian cancer for BRCA1 in particular, also BRCA2. We can save lives with simple interventions. So that's where we can really impact on saving lives for patients.
Okay. I understand that the NHS, which is the publicly funded healthcare system in England, now has a national test directory. Can you tell us more about the directories and the registries in the UK? And by the way, for all the Americans who are confused like me, the UK is comprised of England, Northern Ireland, Scotland, and Wales. I never seem to remember that.
Yes, so we have a National Genomic Medicine Service, and we have a test directory. And we have one it's called rare disease. It's actually germline, inherited genetics, and we have one for tumour genetics. And it does mean, in principle, whether you're up in Newcastle or down in Cornwall, that you will get the same genetic test. The indication would be the same by which you are eligible for the test. You would be tested for the same set of genes, and you'd have the same type of testing, which might be sequencing of the genes and what's got dosage analysis for deletions, or you may, for certain indications, be eligible for a whole exome or a whole genome. But it does imply, it's not perfect, but we are pretty consistent. And then as a community, we have the UK CGG, the Cancer Genetics Group. So we have an enormous Zoom call once a year, and we decide what updates we want to the test directory, and we debate the evidence and so forth. So it does mean that we're reasonably evidence-based, and there's some parity between different disease groups in terms of the threshold that we do different tests at, and the sort of indications and evidence of the interventions.
Interesting.
And in terms of registries,
Yeah.
if you're explaining this to an alien,
Yeah,
it wouldn't
no.
sound that impressive. We have a registry of all our Lynch carriers.
Wow.
Historically, and then they're all registered prospectively, and we're now doing the same with BRCA, which means they're all invited routinely, the Lynch carriers, for their colonoscopy screening by a central recall system, and then likewise with the BRCA carriers. We're just sorting out the historic ones. The prospective bit's reasonably easy. And then they are all registered with high-risk breast screening.
And again, you say right now you're at 5% of the number of the people.
That you would, by modelling the population, the number of mutation carriers that we should have ascertained, we're at about 5%.
So this leads to my next question about getting more of those people. As a researcher in a national leadership role, you consider taking these tests out to the general public regardless of family history or cancer diagnosis. This is something called population testing. And I'd love to hear where you stand on it, and then go down the line and get everybody's kind of rapid fire, quick and dirty opinion on this topic.
So I think you could do population testing. Again, there's a lot of resonance with what Ken was describing, that I work at the Marsden, which is a cancer hospital, and we have developed a pipeline called BRCA Direct, which involves saliva kits, postal testing, a genetic counsellor hotline, an online platform and so forth.
Digital.
So it's a digital, I mean, it's digital, well, it's actually, we have a sort of a paper option as well, because actually the digital was a bit of a barrier. So people can go digital, they can be paper-based. So through that pipeline, we are doing the national Jewish community testing. So anyone with reported Jewish ancestry can have testing, and that's not just for the 3 founders, that's for BRCA1 and BRCA2 sequencing. We're also about to embark on a program where we've taken all of our cancer registrations and matched them with our genomic testing data, match that with who is alive, and we're going to go back and contact historic breast cancer, and it'll be a much smaller number, ovarian cancer survivors. And it means we can kind of go down the list for the young breast cancer cases, the triple negatives, the bilaterals and so forth. And again, use that BRCA Direct pipeline with the genetic counsellor hotline to contact them. And then also using that pipeline to try and smooth over testing an increasing number of breast cancer patients as well. I mean, it's not rocket science,
Right.
but actually it's quite clunky in the clinic, the genetic counselling and the consenting and going off to phlebotomy and so forth. And actually we can take all of that out of the clinic, even for the breast cancer patients. Yeah. They go away, they take the materials away, have a think about it, and then phone the hotline at a time of their convenience after they've talked to the family if they have any questions, and they talk to a genetic counsellor. So I think that's really doable. So I think there's a lot of mileage there, and improving our cascading as well. And actually Gareth Evans just published in the last, between 2013 and 2021 in the UK, we're getting on average 1 mutation carrier per proband. So we're doing really poorly on cascading. So again, that's where there's real mileage there. So I'm not anti-population testing, but I think there's groups where you're going to get a much higher hit rate, and we can do a lot better there.
Interesting. Going down the line, Dr. Welch, what's your opinion?
Yeah, well, the one thing I'd say is, first, to be clear, it's a choice. It's not a public health imperative. It's not going to improve the health of all Britons or Americans. And the second thing, and I think you'd agree on this, is it's got to be focused. You can't, you want to be looking at a few genes. If you're looking for every mutation under the sun, it's a recipe for disaster. I don't know. What do you think?
And Dr. Offit, which genes would you look for, if you can add that? Because would you add PALB to that, or would you just...
Susan and I did the simplest thing in the world, we thought. We would do population screening for the Ashkenazi mutations in Ashkenazi individuals in New York, Philadelphia, Boston, and Los Angeles. You'd be on the internet, you'd call in on the phone, you'd spit to get the results. We would give the results to your doctor would help them to explain to you, right? And so we set up a parameter, because remember, this isn't the UK, okay? We don't have universal guarantees, okay? So we set up eligibility that these folks, right, had a support system to come in with this. So we did a population testing experiment, and we did it with our colleague at Harvard and our colleague at UCLA. So we've done it. So it's not a theoretical discussion, and we presented it earlier, actually presented the details of it, published it. It didn't go very smoothly, okay? Folks were very, very slow to uptake the testing. Their doctors, 40% of them, didn't want to have anything to do with giving them the results of the testing. And the uptake after the testing was not at all assured. So our take is, and there's some other things about the test that I won't even mention here that I mentioned earlier today that led it to be a little bit of, let's say a bumpy ride, right? So we know that population screening, even in a highly selected circumstance, is a challenge. I don't want to say things I'm not supposed to say because I'm on federal advisory committees and I hear a lot of data presented to me before it's published. So I'll say it in a vague enough way that I think it's okay. But, we are embarked on doing a very large genetic study in the United States where we're going to test up to 1 million individuals. And it's getting to be about halfway through, right? The preliminary read on this is when they test individuals for actionable conditions. That means they're things that you can do, right? What percentage of those people will want to get the results of those actionable conditions in a federally sponsored program at no cost?
Right.
Okay, and I'm not going to, and I won't tell you the exact number because I'm not sure I'm supposed to, but if you think it's very, very high, okay, and it's all in progress. But when I saw this, I was, okay, and it's a wake up. So just if you have all the resources in place, and I haven't even gotten to what Claire talked about, which is the return of the variants, you have to have a health system in place. to do the surgeries that you'll have insurance to cover if you have the mutation. There's a litany of concerns that I have, and that's not to say that for all the folks in this room, who have all of those supports and all of those resources, if you want to opt in, and I'm sure that there are programs here that you can do that, then all for it. But I think for the bulk of our US population, I'm very much more comfortable with this approach of testing cancer patients at our cancer centers, where these changes impact their therapy. And we need to do more of that right away. We've been doing it in New York right from the beginning, and it's incredibly powerful. And then take that information and get that to their family members where we know exactly, and that's the cascade model. And that's the one that I actually like the most.
You talked about there being very little uptake in the before study. Can we talk about that psychologically? Why do you think that is? And please chime in if you'd like. Why was it so low?
Yeah, I can just make a quick point. One, just a quick comment. Population screening versus population offering, I think, is actually an important distinction. Population screening means you come into your primary care doctor and they say, you should do this today. Population offering is you could do this today. And primary care doctors make a huge difference in terms of what people do. And if people are recommended something by their primary care doctor or their physicians, they tend to do it. Whereas it's just kind of out there in the ether. They're just not as likely to do it. And so I think that that's been shown in Israel in their population offering study that was sort of alluded to in the study that we did. But it just turns out if you just kind of throw it out there without context, people are just like, what is this? And should this be meaningful to me? So I do believe that there's a ton of low-hanging fruit that's been described by Claire and Ken and others. I mean, we really try at Penn, like we now test over 80% of our pancreatic cancer patients and our metastatic prostate cancer patients and our ovarian patients and our triple-negative breast cancer patients. But out there in the community, that's not happening. Right. So you just, there is so much low-lying fruit out there before we sort of tackle this very complex, logistically, challenging issue of like gene selection and are our primary care doctors ready? Because population offering means that primary care doctors have to be involved.
Right.
And I think that's, right now, they don't want to be.
They don't want to be.
So we have work to do, but we'll get there.
Let me just say, as a primary care, we don't feel qualified.
Yeah.
That's what we don't feel qualified. What do you,
Yeah.
what am I supposed to tell Brigham?
Well, moving on to, we had some questions from the audience, and we had a lot of them. Susan, I will direct these to you for your insight and guidance.
It's going to be rapid fire question time.
And,
yes.
Yeah, and if anyone has anything to add, please do. Does the location of the mutation on the gene determine if you are more likely to get breast or ovarian cancer?
It's a great question. The answer is yes, a little bit, and yet it's not clinically important at this moment, meaning just like you heard about these SNPs and these other little genetic changes that can alter a little bit whether you're more or less likely to develop breast cancer, the location in the gene can have a slight impact on the likelihood of developing breast or ovarian cancer, but it's not enough to change our counseling. So until we can combine all those pieces together, we don't give that information out right now.
Now that PARP inhibitors have been FDA approved, how are clinicians deciding which one will be most effective for each patient, both for treating primary cancers and recurrence?
In the United States, rucaparib, olaparib, talazoparib, and niraparib are approved, and yes, they all rhyme. This is what the insurance, this is what they do. They're approved in different indications just because those are how the clinical trials were designed. So in breast cancer, it's olaparib and talazoparib. And honestly, they're very similar drugs. They have a different toxicity profile. And so it's really nice as a clinician to have more than one choice, because if you get into trouble with one drug, you can try another. But really, there's no great reason to think that one drug is any better. They're just approved in different indications.
To Dr. Welch's point, what work is being done to increase awareness among primary care physicians?
Well, we are trying, but I will tell you that it's not easy. Primary care, I would not want to be a primary care physician because I think somebody once added up all the things that you're supposed to do in a visit, and it would take 8 hours. And I'm actually not joking.
And that
Yeah.
doesn't include actually talking to what the patient was
Right,
talking
yeah.
about.
I mean, it is an astronomical burden. And so, you know, what our techniques have been, we do webinars, we try to get out there, we do education, but we're actually trying to embrace the electronic health record, which I know sounds like an oxymoron, but to kind of say that there are things that are in the electronic health record which could allow us to identify patients who are good candidates for testing and a little bit take you guys out of, not all the way out of the loop, but make your lives easier, because I think that's what we've got to do. We can't rely on the primary care doctors to do this. They have too much to do.
Yeah. Are there any advances in screening for prostate cancers for men with
Yeah, I
BRCA?
mean, and Ken may want to chip in. I think that, you know, really PSA has challenges in the general population. In BRCA2 carriers, particularly who are at very elevated risk for prostate cancer, there's a lot more interest in using age stratified PSAs, meaning that if you have a PSA at a certain age range, that's higher than it should be. There's not a certain cutoff. Also, prostate MRI may be quite helpful in terms of identifying sort of who really needs a biopsy. And to try to address the overdiagnosis problem, there's a lot more watch and wait in prostate cancers when they're not high grade. So these are all attempts that are being made. Obviously, we could do better, but that's kind of where we are right now. Ken, anything else about that?
Yeah, sort of a sore topic because I was advocating very strenuously to a certain one of these bodies on which I sit for prostate MRI. There was a study that was published 2 weeks ago by the group at Harvard on prostate MRI screening exactly in this setting of BRCA mutation carriers, and it was very impressive. You know, the PSA, as Dr. Welch has pointed out, doesn't do it for us. And the MRIs basically resolve the fog of PSA in this high-risk group and did it quite well. Now it's an expensive test. Interestingly, and I've gotten more into this now. I'm a prostate aficionado because we're going to do this modifier study on men with prostate cancer. So we can do the prostate. I don't know how you do it at Penn, but we do it in New York without contrast, which is very helpful. You know. And because they've got the informatics to be able to do that. Because if you don't need the gadolinium injection, that's a big plus.
They don't have that for MRI for breast.
No.
In Europe.
No, but different biology.
Okay.
Yeah, different biology. So in the study that we're going to set up, and hopefully we'll do all of this together, because we do pretty much everything together in New York and Philly. I'm hoping that we'll be able to have that approach. But prostate cancer is a major focus because, as I spoke about earlier, prostate cancers in BRCA2 tend to have higher Gleason scores, tend to be more aggressive, under the microscope. And so we want to be able to make that diagnosis in these men early. Right now, the National Cancer Institute has a study where they'll do it for free, but you have to get on Amtrak.
You have to get on?
Amtrak. Ride down and come back. But insurers will cover it. And as we change some of our policies, I think there'll be more reimbursement for it, and we are seeing better reimbursement. So for prostate, this is right now, and we're really recapitulating, in many ways, what happened with breast cancer. I understand one of our colleagues on the other side of the pond is actually contemplating preventative prostate surgery.
Oh, wow.
We're not there.
We're not there. Let's be clear.
Let's talk about detection of pancreatic cancer and ovarian cancer surveillance.
I think this is where we actually do hope that maybe one of these multi-cancer early detection assays could be helpful. We're not there yet.
When there's no...
right now, we really don't trust ovarian cancer screening at all, and strongly recommend risk-reducing salpingo-oophorectomy, removal of the ovaries and fallopian tubes at the appropriate time. A lot of work going on. I see Andy Godwin in the back. There's a lot of other people trying to work on this, but right now, we're not there. Pancreatic cancer screening, we do have things we do, endoscopic ultrasound, abdominal MRI. I think, there was a large study last year called CAPS-5. Bryson Katona, who is here somewhere, was on that paper. And that's led to some of the enthusiasm, but it is worth stating that there were 10 pancreatic cancers in that study. So I think that we still have, limited amount of data on how much this actually helps and who should get it. Because talk about a lot of screening. If you start at 50 and you go to 80, and you have an EUS or an MRI every year, and your lifetime risk is 5%, I mean, you guys can do the math at all that. We need to do a much better job about who needs what.
Sometimes more harm than good.
Exactly,
Yeah.
there are false positives.
I have
yeah.
time for one last question, which is how do you help patients decide between surveillance or mastectomy?
Yeah, I think, and Stephen Narod is here today, and that was he's done really important work in this area. To try to differentiate, I always try to differentiate three things. The things that doctors recommend are things that improve survival, okay? They decrease mortality. I know I use those words probably a little bit wrong. That's like, you'll forgive me. But if we know that removal of the breast makes you live longer, then you're like, absolutely, you should do it. We know that about taking out the ovaries. That's why we say that. For breast cancer, the best we can do for a mortality benefit is probably in the 2% by age 80 realm, which means that most women don't get a mortality benefit from mastectomy. And if there is one, it's more in BRCA1 than 2. The second, on the opposite side, is that, yes, if you have your breast removed, you decrease your risk of breast cancer, just like if you don't want a flat tire, don't own a car. I mean, that's a kind of an obvious statement. And then in between, there's the issue is that if you're diagnosed with breast cancer, you might survive it, but you need to be treated for it. These are all very individual decisions. And remember, mastectomy has costs. And it's not just just complications, it's things like sexuality and nipple sensation and body image and breastfeeding. And sometimes I think people downplay how real these things are for patients as well. So I think it's really important to have a nuanced discussion about these three pieces of it and how that fits in to their life goals and where a person is in the moment. So not an easy decision, and we try to do it serially, not just as one conversation.
Excellent, excellent answer.
I can give
Oh.
I mean, this is probably this has been over the decades, right? Our most nuanced discussion,
course.
in the field. And I agree with everything Susan said. So the only thing is, I am married, to a breast imager, okay? You have to look at it from their perspective, I can tell you that breast MRI for a radiologist, a really good one, even like my wife who's at a big center in New York, it's hard to interpret. The gadolinium patterns can be tricky to interpret. And she has to see many of these patients that we refer to her for these serial exams. And colleagues do studies of the psychological upset of giving that information. Now you've got to come back in 6 months. Now you have to have another biopsy, right? And you go through this cycle. And again, I've been at this now for a couple of decades, and Jada knows we've done psychological studies. And sometimes, the most sort of psychologically secure folks that we'll meet are the ones who just say, I'm just going to not ever get another one of these scans again. And they'll go ahead and do it. And I will tell you, they're quite pleased with their decisions. That's not everybody, okay? And as Susan said, there'll be many on the other side who absolutely will not want to do that. But this is why, you have to sort of be able, they say lawyers can do this. It's hard for doctors to argue both sides, but we have to be able to see both sides.
Yeah, and it's a dilemma for patients. We have covered a lot of ground today. I want to thank you all so much for joining us, and to our esteemed panelists who are innovating and pushing the boundaries of knowledge for better, faster, and more impactful breakthroughs and discoveries. Our discussion today has been recorded, and of course, if you have any questions, please email the Bassler Center. They are immensely human, and we'll definitely get back to you. Thank you all so much for being here.